Diana and I are just thrilled to have a special guest in our CHNC studio, Dr. Beena Kamath-Rayne, who is the Senior VP of Global Health and Clinical Skills at the AAP, and also a neonatologist at Lurie Children's. Thank you so much for joining us this morning.
Thank you. I also should say I also do some clinical practice through Children's Healthcare of Atlanta. I don't want to leave them out.
Sure. Wow.
Lots of hats.
You stay very busy.
Yes, I do.
Yeah.
I do.
Well, before we jump in, tell us about that. How do you navigate doing you told us, a full-time job and clinical work?
Yeah, so I love the work that I do at the AAP, but I also felt it was important to keep a hand in some of the clinical work. And so I've been fortunate enough to do some weekend shifts through Lurie Children's. I actually work at the delivery hospital, which is Princess Women's Hospital. And in my role at the AAP, I oversee the neonatal resuscitation program. I know you recently had Dr. Henry Lee on the podcast, and so I've heard all about the 9th edition updates. And so I love being in the delivery room and seeing how NRP is being implemented. And one of the unique things about my role is that I also have the opportunity, beyond being associated with the Northwestern group, is to go and do a few weeks of service a year down at Children's Healthcare of Atlanta. And it's very eye-opening to see how different NICUs operate. And
The variation.
The variation, the culture, it's very different. And it's also helpful, I think, in my role for then seeing how NRP is implemented in different settings.
I love that. Well, I have a personal question then, as we're all trying to roll out the NRP, the newest changes in the NRP. I think some of us are getting in the delivery room and we're like, let's do it, let's change it. And we recognize that not all of our systems are moving fast enough to keep up with the changes. So what do you do when you walk into the delivery room? Are you saying, let's do the prolonged, more delayed cord clamping? What sorts of changes are you trying to implement right away?
So I think the first thing I do is ask, are people updated yet with NRP 9th edition? And if not, then I say, okay, we are going to do 8th edition. We're all on the same page about then the mental model that we're all going to follow and the algorithm that we're going to follow. But then I also try to talk about these are the changes with 9th edition. And I think that also involves a lot of education, not just of the neonatal staff, but also the obstetrical staff, because one of the questions is, what is your cord management plan? And that involves making sure that the OBs are on the same page with how long they're going to keep the baby before they would bring the baby over to us.
Huge. Okay. Tell us what you're doing at the CHNC this week.
Well, we have a workshop, which is on Tuesday, which is around the NICU verification program, or the Neonatal Excellence program. So for those people that are unaware, the AAP published Standards of NICU Care Level 2, 3, and 4. It was first authored by Dr. Ann Stark, who I believe many people know.
Absolutely.
And so the NICU verification program is an opportunity for hospitals to see how their hospital is performing in relation to those standards. Now, some states have their own state-specific standards, and so our goal is to offer standards to those states that don't have their own standards or that want to go through a national survey process. So states like Texas and Georgia actually have their own state processes. Georgia actually uses the AAP national standards, but their Department of Health takes the survey and then does their own designation.
Oh, interesting.
The Neonatal Excellence program is an opportunity for an independent group of surveyors to go to a NICU, do a survey. That group of surveyors is a multidisciplinary group. It incorporates neonatologists, neonatal nurses or nurse practitioners, and then if your hospital has surgical services, it will also include a pediatric surgeon. And they will survey your hospital according to the standards. That will involve talking to the leadership. It also involves a tour, and really getting on the ground and seeing how the care is delivered. It also involves an extensive pre-survey questionnaire that lets a hospital see what some of the gaps are that arise before the survey actually happens. So our goal is for this process to be collaborative and that hospitals achieve the level of designation that they want to achieve. So if we uncover gaps, they have time to fix it before the survey actually happens in the second year.
And be proactive.
And be proactive. And so this is really an opportunity to elevate care and improve care. It's not meant to be punitive.
Love that. Can anybody get a survey?
So level 2, level 3, and level 4 hospitals. There are also level 1 standards that are in development right now by the AAP and some of our expert members. And so that is coming soon. But right now, yes, for level 2, 3, and 4. If your state is already involved in one of the state-specific processes, then we would go through those already existing processes.
Very interesting. And do you think that it would be optimal if every state did their own, or we all abided by a standardized set?
I think it should be individualized. I don't think what we're trying to do is create deserts, but I do see that this program could actually help as those deserts are appearing to make sure that those hospitals within referral systems are performing at the level that they should be for those referral networks to be intact. So if you have a system that, there's a certain hospital that should be a level 3, we want to help that hospital achieve that. I also know of some states where, they have a different way of designating hospitals or different levels of care than what the AAP has put out. And so they may have those levels for a reason, and we don't want to supersede what they're trying to do to provide the best care in their state. So, we love it when we are approached by different departments of health or states to help with their care, and we're also interested in working with quality collaboratives and how we can also implement not only the NICU verification or Neonatal Excellence program, but also some of our other resources like the Drive network. We have had a lot of people come to the table interested around Drive. So just by nature of being at this conference, people are interested in registries and improving care through collaboration. And the Drive network was convened by the AAP to study delivery room resuscitation care, and so aligns with what we're doing with NRP. Drive stands for the Delivery Room Intervention and Evaluation Network. And right now it's a group of over 40 hospitals that have delivery rooms, and they are collecting some baseline data around delivery room care. The babies that would enter Drive are those babies that receive positive pressure ventilation or CPAP or more. And then hospitals also report the denominator. So, the numbers of babies born per month, per gestational age, so that we can look at the incidence at which certain interventions are performed. And it's a really interesting story that's developing. There's a lot of variation in things that hospitals are doing, even though we all practice NRP.
Right. Does Drive include all hospitals that perform delivery, so level 3s and 4s?
So a level 3 and level 4 could join Drive if they were interested. We haven't had a lot of uptake in that yet, except for hospitals that have joined in as the kind of umbrella. And so if those level 3 and 4 hospitals join, we can also look at the referral patterns. So a baby that has is part of a level 2 hospital that then is referred to a level 3 or level 4, we can follow that baby for a little bit longer.
That longitudinal data point will be so important.
Exactly.
Are there any outcomes you're particularly interested in?
Well, I think one big question is how we're using CPAP in bigger babies. It's not something that we are able to give really great guidance on in NRP, where we still want more of that evidence base to make a more definitive recommendation. And what we're seeing in Drive is that right now there's a lot of variation in practice. And so we're actually going to be having our first in-person meeting for the Drive site members at the AAP headquarters in February. And so we're excited to start thinking strategically about what's our first quality improvement project going to be, and how are we really going to get different sites involved. There's also another special program I'd like to mention in relation to DRIVE. It's our small hospital grant, and so it's to encourage those sites that are not associated with academic centers to join DRIVE. It gives them a small amount of seed funding to hire like a data abstractor.
Oh, that's huge.
And so it's really targeting those hospitals that are, in the deserts that are at risk of closing. DRIVE actually has a tiered mentorship structure, membership fee, so the smaller hospitals would pay less. Larger hospitals, if they have more delivery volume, would pay higher.
Very interesting. Any other programs we should know that you're working on? That sounds like you've got quite a plate full, but...
Well, I know Henry already mentioned some of the other programs coming with NRP. Under my area at the Academy is also all of our global health work, not just the neonatal, but all of our global work. And it's exciting times right now in the global landscape.
Yeah,
but
certainly dynamic.
Yes. But I think we are in a very unique position. The way we do a lot of our global work is in collaboration with other professional associations, whether those be pediatric, neonatal, midwifery, other professional associations around the world. And I think at a time when maternal and neonatal health is at risk of being overshadowed by many other competing priorities, I think our collective voice is really important to continue to elevate maternal and child and neonatal health as being really important on the worldwide stage.
How we're not supposed to use should, right? How can individual neonatologists kind of join your efforts if they're interested in kind of the global perspective on neonatal care?
Well, we are happy to talk to anyone that is interested to get more involved. First of all, there is a subcommittee on global health associated with the section of neonatal perinatal medicine. They do more of the career mentorship for people that are interested in pursuing a career. They may also do some educational programming. We have a global neonatal advisory committee at the AAP that consists of a core group of 16 individuals and then a larger content expert group of around 40 individuals. And these individuals aren't necessarily members. They could be neonatologists, pediatricians, midwives, obstetricians. There's representation from over 15 countries around the world, and they help guide our neonatal global work. And some of the things that they're working on right now, one is many of you may be aware that the Helping Babies Breathe program, which was a flagship program of the American Academy of Pediatrics, the learning methodology from HBB, which is very skills-based, peer-to-peer mentoring, train the trainer, has been adopted by the World Health Organization and incorporated into their Essential Newborn Care course. So our GLONAC members are still working on implementation and also developing complementary tools and resources to continue to disseminate and implement ENC. We also, our GLONAC members are working on a neonatal transport course that's geared towards low and middle income settings. And then there's also a perinatal loss toolkit that they're working on. Wow. So you may be familiar with HBB or ENC. There's the various zones, so the green zone, the yellow zone, the red zone. And so we are preliminarily calling this the white zone. So for those babies that require advanced care and they may not be on the path to surviving, or mothers that have a stillbirth. This was meant to provide tools and resources. It's not algorithm based for both families and staff dealing with those situations.
Wow, that's innovative.
Really?
I love that. So what I'm hearing is that there's both opportunities within the field if you are already involved in AAP or registered as a member to start to get involved in some routes, but even some ways to get involved or do some of this work without necessarily joining the American Academy of Pediatrics.
Absolutely. And there are ways to get involved in the development of the materials. We oftentimes will do a call for volunteers when there are openings on GLONAC. And then also once the tools are developed, we love people to help with implementation and dissemination.
That's right.
Yeah.
Absolutely critical. I mean, I'm embarrassed to say I did not realize how much work was being done by the AAP on a global scale. So I really appreciate you coming here and telling us all of the things that you have been spending a lot of time and a lot of effort
Absolutely.
in doing. And we're looking forward to hearing more about that. Dr. Kamath-Rayne, thank you so much for joining us.
Thank you for having me.
Our pleasure.
See you later.